Hi, good afternoon, everyone. Thanks to those of you who have joined us thus far. We're going to go ahead and just give it a moment for folks to trickle in from the waiting room, and we'll get started momentarily. Okay, we're going to go ahead and get started. Welcome, everyone. I'm Jessica Little, Vice President of Programs and Operations with the Civitas team. Thank you all so much for joining us during the final busy few weeks of the year here. We're very excited to be hosting our partners and members for Medica to talk about Stop Waiting. Identity management is the new interoperability foundation for whole person care. Before we jump into the presentation, just a few reminders. This is a Zoom webinar. All participants are automatically muted and your video is not displayed. We would, however, love to know who's on with us and for you all to introduce yourselves to each other. So if you want to use the chat feature, introduce yourself, share your name, your organization, and location. Throughout the event, if you have resources you want to share, please plop them in the chat and we'll share them in follow-up. If you want to ask a question, please use the Q&A function so we can track those questions, but we're also always monitoring the great conversation that happens in the chat. As always, or most of the time, this webinar is being recorded and the recording will be shared after today's event. And as always, if you have any questions, please reach out. So quick introduction. I'm just going to be here to kick us off today, and then I'll introduce my colleague, Demery Henderson, to talk a little bit about Civitas Networks for Health, and then we will kick it over to our partners at Formedica, NJII, the New Jersey Innovation Institute, as well as Convergent Health. So with that, Demery, over to you.
Awesome. Great. Good afternoon, everybody, and thanks for joining. My name is Demery Henderson, and I'm the Grants and Programs Manager here at Civitas. And before we get things really moving, just wanted to provide a quick overview of Civitas Networks for Health if you're not already familiar. So we are a nonprofit mission and member-driven organization, and we're focused on improving health outcomes for all through health improvement and health data exchange. And we bring together organizations working to use data to improve health in our communities across the country. Go to the next slide. Yeah, so who we are, our membership includes HIUs, regional health improvement collaboratives, quality improvement organizations, and others taking data-informed multi-stakeholder approaches to health improvement. So our membership is very diverse. We have about 160 members, and these integral organizations are on all levels of our communities. So they're at the local level, regional, state, and national. And together we invest in data-driven collaboration to enhance health, address cost, equity, quality, and safety. And one of the great things about the Civitas network is that our members are able to utilize the Civitas platform to connect collaborators working on health improvement across the country. So at Civitas, we really believe that local communities should lead and influence the national progress on health. And to do that, we offer forums like this one for our members to share learnings, share education, provide network opportunities, as well as advocacy. And as I'm sure we all know, the healthcare landscape is ever changing. And so we really find strength in having convenings and webinars just like this one today to share knowledge within our network. And with that, I believe I will hand it over to Greg Church at Formedica to go ahead and kick us off with today's great presentation on identity management.
Thank you, Demery. I'm going to share my screen, so it might take me just a second, so bear with me, everyone. Can you guys confirm you're seeing this and me? Hello?
Yeah, we
can see the screen, but not you yet.
Okay, can somebody turn me on, or do I have to stop sharing to do that? I might have missed that step here. Hang on a second. Okay. Hopefully you guys can see me now. Are we good?
Not yet.
Well, that's unfortunate.
There you go. I see you now.
Looks like I'm a little blurry. Am I blurry or am I okay? All right, here we go. Welcome, everyone. Good afternoon. I know it's the holiday season and there's so much going on, and I hope everyone is planning, for a great time with family, friends, and just to enjoy the season before the end of the year. So we're excited to be here. The title is Stop Waiting. Identity Management is the new Interoperability Foundation. We really are advocates of all the different initiatives that are going on today, and we have been, watching carefully around some of the national initiatives with CMS. But we believe in this group that's here today that we really need to kind of step back and look at what are some of the barriers that are going to prevent interoperability from really taking off and being effective, but also making sure that we don't compromise any kind of patient safety. But as we're looking at whole person care data now coming together, and there's so many cool initiatives around that, there's some things that we believe that are going to be important as everyone kind of wraps up this year, starts the new year, and starts thinking about what has to be the focus as we go into to 2026. So if you don't know me, I'm Greg Church. I'm the president here at Formedica. We're a 26-year-old health IT company really focused on achieving whole person care. We champion the need for a single source and a longitudinal person record, and we're going to talk a lot about that today. But we really focus on leveraging our enterprise master patient index and automated worklist management technology. And today, we are really proud that we work with many of the HIEs that are on the call today, the community information exchanges that are represented today, provider groups that are out there. And I think as of today, when we looked up the numbers, we represent about 150 million patient identities that we support across the various networks nationwide, and the high demand for accuracy and patient identification as we're really talking about whole person data management. With me today, I have Jennifer D'Angelo. Jennifer, why don't you do a quick intro of who you are and a little bit about NJII?
Sure. Good afternoon, everyone, and thank you for joining us today. I am Jennifer D'Angelo, Chief Operating Officer and Executive Vice President of the New Jersey Innovation Institute. We are a very unique organization. We are a subsidiary of NJIT, which is a public university in New Jersey. We also work very closely with Department of Health and Human Services. We manage and operate New Jersey's Health Information Network. And so that's what we'll be focusing on today with our clinical use cases, managing the HIN, identity management, and just overall HIE experience exposure, and where we've come in all of these years of putting health data together. So a little bit of my background: I've been a chief information officer in healthcare facility on the provider side. So I come to this with provider knowledge and experience, which I think is really critical to shaping the way that we leverage digital transformation in healthcare and in this space, and safely connecting the dots to make sure that we are passing information appropriately from provider and giving consumers back their information accurately. So really great to be with you all here. And as part of the Innovation Institute, we also have other industries that we support in addition to healthcare. So we do a lot of AI work and solutioning for healthcare organizations and other industries. We work a lot with Department of Defense and advanced manufacturing. And we also have a entrepreneurship program where we have a venture studio. We invest in newcos and startup organizations. So that's just a little bit about who we are and what we do here at the Innovation Institute. Thanks, Greg, for having me today.
Excellent, Jennifer. And Laura?
Thanks, Greg. I'm Laura Young. I'm with Converge Health. I'm the co-founder and managing director. We're a professional services firm that specializes in the last mile of interoperability. And really, when we say that, we're addressing some of those edge use cases that interoperability organizations, HIEs, and other organizations such as that have struggled with connecting. So we provide the advisement around really how to bring those use cases to the forefront. And we work with vendors as well in terms of helping them understand really that last mile piece, whether it's from a behavioral health vendor who doesn't know how to necessarily do interoperability, or sometimes an interoperability vendor that's really trying to understand behavioral health and social care exchange. So those are the things that we specialize in. So happy to be here.
Excellent. Great. Thank you, guys. So a little bit about the agenda. There's going to be some actual live polling questions. So get your cell phones ready because we'll have a QR code where you can actually scan it to participate and see a live poll and see the results right away. And then we also will have a QR code at the end if you want to post very specific questions that we can address. I know you can also post them in the chat here as well. So we're going to really focus on just a few areas today in the presentation, a little bit around what we call the crisis, around patient identification and why it's such an important need. Talk a little bit about the fix, right? What we can be doing collectively together, even though we don't have a unified patient identifier at the national level, there are things we can do together in the ecosystem that can help strive for better matching and accuracy. We've got a few case studies that we actually want to point to that kind of talk about the approach and some of the different things that are going on at the national level as well as the regional level. And then, of course, we're going to allow for Q&A. So we call it the broken link. And person identity misidentification really is the critical barrier to whole person care and achieving that last mile interoperability. And Laura's going to spend more time about some of those, use cases that are important as we talk about connectivity. But first, we really believe that we have to solve patient identity, right? Misidentification is, at this point with technology where it is today, it's an unacceptable risk to patient safety. And it really is the root cause of some of the systemic financial waste that also goes along. So our call to action is, how do we standardize demographic data, right? And implement advanced EMPI solutions, right? But we also want to talk about how do we automate kind of that gray zone, that work list automation area, regardless of your MPI. And there's some great MPI technology out there, whether it's integrated right into your platform, it's a standalone SaaS product, and there's vendors that are represented even on this call today. The software is critical, but what we do to manage work list and to automate that and to be able to keep up at scale today with the number of transactions that are going through electronically is where we need to focus and really to be able to eliminate those manual errors and costs while still advocating for building those national standards. So we're going to build this discussion kind of around that premise today. So I'm going to turn this over to Jennifer. She's got the next couple of slides and she's going to address, kind of the risk side and some of the things that are going on at the actual network level.
Sure. Thanks, Greg. So thanks for teeing that up for us. So two sides of risk that we want to focus on here are, of course, patient safety, and then also the financial burden. So with wrong treatments and tests and clinical and critical information gaps in care, delayed diagnosis, adverse drug reactions, timeliness of information to the patient and the provider. All of us that are managing HIEs have these struggles of how do we know that this information is real time, and how are we looking at getting the information that's critically necessary to care for patients at the time that they need it. So patient safety is top of mind, of course. And I was sharing with Greg when we were preparing for the presentation that consumers are getting very well educated on where their data is located, right? And so I feel, and we get a lot of questions here in New Jersey, and when we were also running some other HIEs from consumers that are actually logging into portals and looking at their information and making sure the information that they're seeing about their record is accurate, right? So I can't tell you how many times we've gotten feedback from patients saying, we want to we want to stop participating in an HIE because we feel that our information is being wrongly transmitted and the wrong information. And so you kind of break that down a little bit and you say, well, how's this possible? This is coming directly from your provider's office. We don't manage that data. We just transmit that data. So really understanding that and educating the patient and consumer that they've got to go back to their provider to look at those results and that information that's within their chart. And that's not the responsibility of an HIE to fix, right? So depending on how your state is configured and your health information networks and exchanges are opting in and opting out of services, that really happens at the provider and the health system. So we encourage patients to go back and say, if you see something that's wrong, you have to change it and correct it. And their fear is exactly this. It causes patient safety issues if they have incorrect information happening from one provider being transmitted to another provider. So that is significant. And then along with that is the financial burden, right? So administrative waste, manual remediation of effort, liability exposure, denied claims, and the financial list can go on and on. Just the administrative manual piece, not only is it a financial burden, it's high risk. We're doing manual work. We should be more efficient. And we're in a day and age where technology is moving at the speed of light with AI solutions and efficiencies and administrative workflows that really can be streamlined, providing you have the right identification management protocols in place to link those records. So it's not just about checking the box that you have information going into your EHR, checking the box that that claim got out the door. It has to connect to each other and making sure that that patient and their identification and management of their data is all synced across all systems. And so as we continue to look at the interoperability landscape in healthcare, we're doing so much more in connectivity instead of sometimes looking at the bigger picture and consolidating connections. I feel some days that we're creating even more connections and integrations to systems because we're still not quite yet solving all of the problems and opportunities that we are being faced with within this landscape. So I'm going to invite Laura and Greg to jump in where necessary or where you feel like you can add some feedback to the slides. I want to make it pretty informal. But this is a significant challenge across the board. And the more we have these conversations and talk truly about what is challenging for the space, how is it financially burdening health systems and health information exchanges and the like, it really starts to educate on what's the root cause? How can we come together and fix this? Because the technology is there and that's not the problem. The problem is connecting the dots. And that's what I hope you'll continue to hear throughout this presentation is, we want to look at whole person care. We don't want to take just a snippet of a person's record and just use that in a silo. There's no reason for that anymore. There's such a greater opportunity for us to come together in a collaborative way to brainstorm on the best way to handle this and minimize the risk associated with patient safety and financial burden. Not only financial burden to the provider health system, but to the government. I mean, just financial burden across the board. So some systemic costs of misidentification. There's certainly a safety threat, harm to a patient due to missing history. And so why do we have missing history? We don't have the dots connected, or we mismatch those dots and they're not connected appropriately. There's a financial drain and strain on the system, the millions of dollars in lost operational inefficiencies. We keep saying we're using technology to become more efficient, to be more cutting edge, to make more meaningful connections and integrations. And then we find that that's not always happening. And when it happens, it's an inefficient process. There's still a manual component to it. And we may still be missing components that are contributing to that safety threat. The interop barrier. Data can't flow from the WHO when the who is unknown. So if you have data to exchange and you're not sure where it goes, it stops at point A. It doesn't get to B, C, D, and E, and to those trickle down areas where it's needed the most. So really identifying those barriers is significant. And again, communicating, working with your partners to be able to identify that. And just because your systems are on and data's flowing, that doesn't mean the right data is still going to the right end resource and endpoint. We always have to check along the way that the quality controls are in place to make sure that we're looking at all of these various buckets of where we could spend a significant amount on misidentification. And then, of course, lastly, the legal exposure. That alone can be millions upon millions of dollars in exposure and increased risk of malpractice suits and not being able to have that information follow the patient appropriately. I mean, I don't know how many of you, but we go to the doctor, we're patients also. How is our experience? We're all tech savvy enough to know that when we go to our provider's office and we log into our portal, we expect to see the things we spoke about during that session. And then we also expect that session to be transitioned to the various endpoints that our records are supposed to flow through. And that doesn't always happen. And it is very frustrating that we're still having the same discussions in an emergency room and being asked the same questions over and over again when systems are not connected correctly. And even more importantly, when we have misidentified the patient record to be able to properly care for that patient. So I speak very passionately about this. I'm handling a lot of elderly family members right now. So misidentification and interoperability, care transition, whole person care and record is very near and dear to me professionally, personally, and it should, one of the reasons why I'm excited to be here with my partners to continue to highlight this and talk just about the importance of what this means. This isn't a tech issue that can be easily solved. This is operational process. This is an everyone coming together collaboration opportunity.
Great. I think that is excellent. So I'd like this next slide, kind of more of a group discussion here, and I'm going to include Jennifer and Laura. I'll kick it off because I think everyone who's attending the webinar and just coming off of recently the Civitas conference with the 211 organizations and San Diego helping to sponsor that. There's data blending now like we've never seen before, right? You've got merging of health information exchange. You've got now community information exchange, folks that represent the clinically integrated networks. I believe we have one or two on today. These data streams now are creating massive duplication, right? How do you manage these data streams when they're coming in from so many different sources of data? And it's great to see this convergence of data, but with data comes more challenges, right? So Jennifer, I'll kind of kick it off to you again. Talk a little bit about what are these data quality challenges and what can we do more cohesively in the ecosystem to address these?
Thanks, Greg. So what I was alluding to a little bit before is just the fact that we're receiving data, box checked, but what's the quality of that data? So it's really paying very close attention to data stewardship, your data governance, protocols and programs, and working with your data sharing organizations, provider practices, health systems, as a collaborative process to look at what is being sent, right? So I'm glad that you mentioned data blending. So, our landscape is becoming more and more complex with different sources contributing and sharing data and merging depending on how your state is configured. I can give you examples for our state where we have our health information network that sits at a higher level, but we also have really critical regional health hubs and HIEs that are connecting that information from us downstream, and they're reaching consumers and providers. We have now CIE, which is bringing in the social aspects and CIN data, and we're creating all of these inputs and integrations that are critical to look at the whole patient But if we're not all connecting on an identifier and a single source, and I keep using my hands to say, like where you're connecting Legos, you've got to make sure that those pieces are fitting. It's a piece of a puzzle that has to match in order for that record to pass through to the next level and the next level and downstream. And like I said, having governance and data quality protocols in place where you're really looking at that immediately. And that's something that has to be ongoing with constant reporting and dashboarding, real time looking at the fields that are being populated correctly with the data you expect to be in that field. Not just that there's a value, but what is that value? So so not to get overly technical about it, but yes, looking at dirty records, legacy systems, how clean is the information that we're putting in and we're really transmitting to others? And how often do we go back and actually hold people accountable to say, hey, we're getting a lot of this data from you, and this really isn't making any sense to us. Let's get on a call and kind of figure out where's the root cause of this, because you'll often find that it's at some point in the data entry process on the provider side where there could be a disconnect. And the simple disconnect to be lack of education or really an understanding of they're inputting information, not realizing downstream where that's going. And that all starts with registration and then it just continues. So, and that's why I love having that provider background to be able to appreciate that hospital provider setting and how important that is, that first point of data entry to the rest of the continuum of those records and really connecting whole person care.
Excellent, excellent. Good points. So Laura, let's talk a little bit about consent and behavioral health. How does this fit into the challenge, right?
Right. Well, and as if data quality wasn't complex enough, right? Then we go and magnify that with some consent and adding different levels of data that require different privacy and security. So behavioral health and substance use information, they have added layers of privacy protection. Requires us to manage permissions correctly to a very high degree of identity accuracy. And so knowing that identity across those, the consent layer is pretty important. And then you need to add in clear governance. So I think communities feel the pressure most acutely when they're trying to operationalize whole person care. And, as Jennifer was saying, this isn't a technical issue necessarily. It's really the predictable result of integrating data that comes from different missions, regulations, operational cultures. The important shift is recognizing that whole person care requires us to confront these structural challenges directly rather than just working around them. And really the last mile is where the accuracy matters the most. It's the point where a record becomes a real decision. It's a care manager picking up a case, a crisis team responding, a clinician adjusting a plan. And if blending data quality or the consent breaks down or doesn't work well, it breaks down at that last mile. And so I think understanding that tension is critical for designing systems that serve people instead of just moving data.
Wow, great point. So the true cost, right? So we're talking about the barrier, we're talking about the risk. It's probably not a surprise to see what's on the screen. There's a fairly significant risk here, right? 10% of patient deaths annually are tied to incomplete patient views and identity mismatching. Think about that, 10%, of a million, what that equals, of 100 million, what that equals, right? Jennifer's point is well taken. Not an IT problem, right? Now it's become a human safety issue. And what we have to do is step back, look at what we do from the process side, look at how technology is being layered in. But now we have to look at it from the beginning of the process. And I think the point was made nicely that a lot of this may just be understanding of how to register patients. What are the rules around registration? How do we categorize certain things more organized and in a systemic way? So the focus is, if this is where the risk is, and we are putting patients at risk at this level of frequency, now how do we back into it, right? What do we do to actually put some action into this? So we'd like to do a polling question. Just from your perspective, get your phones out. We'll give you, a minute or so here to get your phone out and scan the QR code. But the question that we're asking, and you can only select one answer, so read them carefully. What consequences of identity errors are you seeing most often across your ecosystem as the participants on this webinar? We'd love to have you answer this question just to kind of get a perspective, for where we are collectively. So go ahead. We'll give you a moment here to answer. Pick your question. Pick your result, I should say, your answer. Kind of scroll so we can see this. Wow. So look at, answers are still coming in. We're at 80% of this group is concerned around duplicate or mismatched patient records. So it's a fear, right? It's a concern. Everyone, I think, wakes up as part of their day-to-day process, especially if you're leading your organizations, wondering with all this new, transformation and moving data, in real time, are we doing it reliably, right? So you can see the next kind of big group is provider frustration or workflow disruption. Delays or failures in data exchange, 20%. Gaps in whole person care coordination, 20%. Difficulty coordinating behavior, health, and consent, 10%. And then patient confidence, which we are patients, right? We are actually consumers of healthcare on this call. Our confidence level, a little surprised that's at 10%. I thought that might be a little higher with this group. But I think with the urgency around some of the things that we have to do responsibly, the patient matching component is not a surprise. So right on. The problem is accelerating, right? Data volume versus manual remediation capacity. Data volume's going up just in massive amount of scale. But our capacity limit, the manual process, relatively flat. Guess what? That is not going to keep pace with the exponential growth of health data. And this is where we have to stop, look at how we're actually manually looking at those probable matches, right? Not what the system is identifying. Deterministic matching is not our problem. We know that we're catching probably 80% of what needs to be matched. It's that last 20%. And that 20% is only going to continue to grow as you're now merging, or you're bringing different data sets in, or you're partnering with different organizations in your community. How do we, as HIE, CIE, SINs, take on that burden, but you don't have control of the whole process? So we're going to talk a little bit more about that. So I call this slide from crisis to foundation, right? So let's now focus on what can we do to build a more stable future for healthcare data. So we call it single source of truth. And we're actually kind of coining this phrase WPDM, or whole person data management. It's known out there in a variety of ways, but because we do have CIE networks and HIEs coming together, we've got SIN networks coming together with social. We're really now looking at it from not only the patient perspective, but it's the whole person's data, right? So the data can be everything from clinical to social to financial. It doesn't stop. And the more we can bring better data together, we can actually get to better outcomes. We can actually get to better clinical trials. If we're using data responsibly, we can get to better understanding of how to prevent before things happen. So the whole point is integrated care cannot succeed without a single trusted source of truth for patient identity. And we're making improvements. We're seeing improvements, and we're seeing identity proofing with companies like Clear and others coming on board to help with that. But that doesn't address the whole audience. You've got long-term care patients that are not necessarily sitting there being able to validate their own identity. You've got the transient homeless population, not probably going to be able to do that. You've got minors, the list goes on. So we have to think through, what do we do to capture not 80%, not 90%, closer to 95 to 100% of the person's identity correctly. So we want to create the centralized, accurate index that links all patient data across the care continuum and ensuring that the right data reaches the right person at the right time. Just coming out of, being in Washington, D.C. and going to the Connectathon with CMS, and we're hearing that we want to empower people to have their medical records in their devices, their phones, and then be able to have that device go into a new medical provider, have somebody scan a QR code and have that information upload into the EMR. Sounds great, right? But is it great when we're not totally 100% sure that the data that's reaching the new provider office at the right time when care is needed is actually the right information? So how does this work? Well, there's really 3 steps, and then we're going to kind of drill down on this. There's the ingestion step where you have to make sure you cleanse and standardize multi-source data, right? So we know it's going to be coming in from different sources, but we have to have those tools and everything in the process built in to when we actually start the ingestion process. Now we have MPI running. We can do referential matching, right? Where we can use very sophisticated external data sources to help us validate the match. And then along with the MPI, we should be able to get closer to that perfect match. But then we have to think about the work list, right? Those probable matches. And we're going to talk a little bit about how we're going to be able to help handle that in a little bit more of a streamlined, automated manner. And then more importantly, the quality out, delivering what we call actionable, trusted patient records, both to the consumer who's going to have more control for patient access and also to the providers, the care team that has to rely on that accurate data. So, Laura, I'm going to turn this over to you to talk about what you're calling, and I've heard you just mention it on this call, what we need to do to enable last mile interoperability.
Yeah, so we have some standards. Oops, we went past the slide. Standards on this slide, and they're really the backbone of whole person data management. And so when we talk about last mile of interoperability, we're really talking about what happens when data finally needs to move in a way that real humans feel. And that really only works when everyone speaks the same technical language. So like the standards and that are listed here, that really gives us a shared vocabulary. Whole person care requires more than clinical data. There's SDOH needs, behavioral health information, imaging, medications, claims feeds, and public health reporting that all live in different systems. And so the standards make these ingredients compatible so they can come together in a single trusted source of truth. And then the standards accelerate trust across the ecosystem. So EHRs, HIEs, payers, public health agencies, they all bring a piece of the puzzle. And so when the data conforms to common standards, we reduce the friction and we improve match rates and strengthen the confidence in every downstream decision that providers are making. So really, this is how we close that last mile. A lot of organizations can exchange data in the middle of a journey. The hard part is making that data usable at the edges where care is actually delivered. So standards ensure that the data arriving at a clinic, a shelter, crisis center, an EMS team, it's structured, it's clean, and it's actionable. And of course, we've talked about data quality. And so of course, it's got to be reliable data as well. And then we've got the patient matching piece in there that's making sure that we're accurately presenting a whole picture of a person. So that better standards mean better identity resolution. It's really a prerequisite for whole person data management. Standards support the consistent coding and the cleaner attributes and more reliable merging of records, which dramatically reduces the duplicate charts and misidentification. So really it powers everything from analytics to coordination. Once the data is standardized, organizations gain the ability to run predictive analysis, detect gaps, support referrals, align care plans. And you can't really do any of that with fragmented or proprietary data models. So that's really why these standards are pretty important. And as TEFCA expands and CMS pushes for structured care and all these different things that we're kind of hearing the buzzwords about, and the states are scaling more cross-sector work, states and counties, regions, the organizations built on standards can adapt more quickly without ripping up their infrastructure. And I think that's pretty important.
Excellent.
Greg, I just wanted to, did you want to field questions as we go? Because I'm monitoring the Q&A, or did you want to hold those till the end? There were 2 questions specific about the last slide.
Let's do it. Let's do the questions. Let's
Okay.
keep it interactive.
Perfect. All right. Can you share details about your referential matching capabilities and how it works specifically? What sources are used and how?
Sure, that's a great question. So referential matching is really kind of a fundamental layer in the match process. So again, deterministic matching where you have your scoring, your rules, your algorithms that capture the bulk of your identities. You layer referential in, which is really partnering with external data sets. There's some great public data sets that are available through companies like Thomson Clear and others that bring in financial data, bank record header data. There's the social, some social data. It's still limited, but there's mailing address normalization, which is part of how you can match better on the addresses itself. So when you partner and look at data, also think of referential as not only external data sets, but what other partners in your ecosystem have data sets that you're not bringing into the match process that can further enrich the demographic data quality. Remember, people move around a lot in the course of their life. And so historical information, historical mailing addresses, their cell phone numbers, even old landlines, we don't use them today to actually make phone calls, but that data is still out there. And that data can be then propagated to bring together and fill in gaps where if somebody is moving around or they have a higher rate of transposing their names because of marriage or they divorce, you want to look for all those different missing data elements. The more you can enrich with referential matching and bring in historical data and not have limitations on how much data to bring in, only increases the match rate. Because think about it in a community, multiple hospitals feeding into an HIE, a person's record may not be updated as frequently from one health system to another. So the more the HIE or the Health Information Network can aggregate that historical data and store it at the attribute level, only enriches the matching and the match rate. So again, talk to your vendor, talk to your partners that are doing MPI, make sure that they understand what referential matching is and how to go get data, how to leverage other data sets that maybe you're not bringing into your data set. And then even one step above that, once you do referential matching, if you have new data that you go find, enrich it. Bring that new data information into the record because it just makes the data set more complete and comprehensive. Next question, Jen?
That was great. Thanks, Greg. As you were talking, I was thinking about myself and my last name with an apostrophe. I can't tell you how many times my information is input into systems, older systems that couldn't take symbols and apostrophes, and my name is misspelled in so many different health systems. So I would be a good use case on my own tobacco for identification matching because it could be D space A, DA, DEA. Like you would see a host of all these different ways in order to do that. And so it just makes you realize like this is a real, and that's like one little piece where historical data could be really significant and impact matching and enriching that data and the capabilities. Next question is FHIR listed twice, or are you differentiating between FHIR and HL7 FHIR, and if so, how?
Do you want to take that, Laura?
Well, I did not put together this slide, so we just love FHIR so much, we put it on here twice.
I think it's a duplicate. So
yeah. But it's a great call out. But no, there's no difference. I think we wanted a nice even box, and somehow we ended up with FHIR in here twice. But that's just because FHIR is so important. And actually, to be honest, I mean, I think it's amazing how much the needle has moved around FHIR, and how much I'm starting to really see organizations using FHIR. That said, though, we're sort of talking about that last mile. You're not going to see as much FHIR in that space. You're going to see a lot more CSV files and spreadsheets and things like that, where some of these organizations are not on the most robust systems. And so kind of emphasizing again why the standards are so important. But we also have to meet people where where they're at. So you can have all of these amazing standards, but if you're working across an ecosystem, meeting them where they're at, regardless of standards, is also important as well. So
I love
Good
that you
catch.
called that out, Laura, too, because earlier adopters of systems are still continuing with those systems, but the rate at which they've accelerated, some have stayed in the game and they are up to standards and certified systems, but other smaller provider practices that don't have the technical infrastructure, finances to change systems are often left with systems that really have not been invested in and are a big cause of those delays in how they're able to even export data, exchange data, or limited capabilities in that space. And we see that a lot in certain provider spaces where the tech just doesn't meet the requirements and the standards and the needs. And that is just a significant issue that really impacts this whole ecosystem.
Great.
So thanks for bringing that up.
definitely.
Yeah.
So let's real quick, and we'll keep the conversations going because I know time is going to run short on us here. What we call the whole person data management difference. I think it's obvious, but just to kind of point it out. I mean, today, kind of the before, right? We've got disconnected silos, duplicate records, and uncertain identity leading to fragmented care. Okay, we know that's been the challenge up to this point. The goal, right, getting us to the after is we want to be coordinated. We want to have confident care. We want to have a full longitudinal record now that follows the patient or what we call the person, right, everywhere. So we want to spend a minute or two. I think there are a couple of interesting use cases that bring value to the conversation. I'm going to take the first one because I'm going to actually focus on what a health system has actually done, right? So Boston Medical Center, they are a very large health system, right, in the Boston area. They're going through an interesting transition. A lot of health systems are not only connected to their HIE, right, and providing data value at the community level, but they're also growing, right? They're actually going out and they're acquiring other institutions, bringing those data sets in and having to integrate a patient, right, into a single, in this case, Epic EHR instance. Now, that sounds easy, right? Well, it's not, right? Because you've got different EHRs out there. You got different ways that records were created at the registration level. So initially they had failure, right? Their existing matching rules were way overwhelmed with acquired data quality issues. They knew they couldn't tackle it alone. They reached out, they found Formedica, and in this case, we looked at their work list with them and said, look, if you're going to manually try to match a work list comprising of nearly 10% of your patient records, doing it through the manual human way is not going to be achievable. And the reason we're bringing this use case up is we've learned from you guys, the HIEs, right? We're applying HIE expertise to even the provider side. Why is that important? We call it kind of HIE grade matching. If you think about what you have to do as HIEs and HINs and CIEs and SINs every day, you take in data from all these sources that you have absolutely no control of, but you have to figure out how to create rule sets. You have to create and categorize things that are commonly coming in across multiple data feeds. And that rule set then becomes the way you match, right? So we helped build this process. We call it IdentiMatch. It's a worklist automation solution that actually helps bring in the data stewardship team. They sit down and help build those categories and those rules with us. And then we bring in a much better data cleansing process for any upstream data available that's coming in. So what we've tried to do is take what the humans have done, but they only can do it so fast in a given, shift, or they're in their job. And we built it on a much bigger, robust engine that now we can take the expertise of looking at multiple data sets coming in from a variety of data partners and be able to build quick rule sets and then be able to manage that in an automated fashion. So where you're using less humans to have to look at every record, which is almost going to be impossible. So what we try to do is empower now the provider groups to take affirmative action, quickly be able to look at their own work list and say, how do we solve this? how do we improve our own internal matching requirements? But now, as we're connected to an HIE or we're sharing data across the national networks, we become much better participation, right? So we're not going to be able to create higher risk. We're going to lower that risk. So they had a requirement, Epic, as we know, when you bring data in and you're going to Epic or you're bringing more data sets in from other EHRs, they actually have a 3% duplication rate requirement that you have to be able to demonstrate that you've got your probable matches, your overall duplication rate less than 3%. And so with the implementation of the Formatica IdentiMatch process, we actually got them there. We actually did it with lower cost. We didn't have to increase the HIM folks to do it. We got them to a manageable level now where they can actually manage that going forward. But their HIE is really going to benefit from it as well, because now the transactions coming in actually are going to be much more viable records and increase record value quality. So that's one use case. So Jennifer, I'm going to turn it over to you because you're really dealing with it at a different, broader perspective as a larger health data utility.
Sure. So thanks. When we look at community-wide data utility focuses and achieving health data utility, there so many components come to mind. Leveraging what we have as a health information network and exchange and building that out to really serve the purpose of health data utility. And I know that many of you that are managing HIEs across the board are also working on this as well. But the core that's needed is the trust factor is essential, not just for HDU, but as we've talked about, all of these integrated networks. What's going to connect across the entire community so that data can follow the person across all various systems, and trusting the foundation that the organizations really need to rely on for accurate and consistent identification matching. A trusted MPI, accurate, deduplicated patient identities. There are plenty of systems within your EHRs that can quickly give you an alert that you're potentially inputting a duplicate. We override that. Then there are other reports that can be run. And then we have other services in the background that look at duplicative information and try to consolidate and merge. But the key components for success for this really are having that trust and being able to reduce those and dedupe those identifications, and looking at granularly the consent management piece, respecting privacy and control, where the patient has control over their data, where it goes. And so we hear that more and more as consumers become more educated on all of the various areas where their information can and is being utilized. How many consumer apps are out there where it's a free app for the consumer, and the consumer doesn't always realize that the data they're contributing to that is being monetized and commercialized, right? So understanding where that information's going. Again, better reporting, enabling analysis and responding, and then the full impact on whole person care, where it's safer, tailored treatment, complete records, seamless experience, empowered voice, and just a satisfier where we could start to really rely on health tech systems to provide the full story. There are no gaps, and then we start to really trust the process and those that are all involved in that process. And it empowers people, giving them control on how their data is shared and knowing that it's being used for the proper purpose.
Excellent. So let's talk a little bit, Laura, about impact, right? Around policy, community, and ecosystem influence, right? I think this is probably a good way to start bringing this together here, towards the conclusion.
Yeah, so our goal is really that complete view of the person. This whole webinar is around whole person data management, right? And so partners outside of traditional healthcare hold critical data that fills gaps that EHRs can't touch. Whole person data management only works when those voices are at the table from day one. Early integration keeps information flowing where it matters most. It prevents the classic handoff failures that happen in the last mile between clinics, behavioral health providers, social care agencies, and justice settings. And then we can address social drivers with precision. Participation from community partners illuminate the real drivers of health. This is how the ecosystem closes those gaps that no single provider can solve by themselves. And policy and compliance alignment, if the stakeholders co-design the data strategy early, then compliance doesn't become the brakes later. So instead, we get the guardrail that supports the scale and the trust and the sustained interoperability. And then in terms of how better data value drives coordination, we want to translate whole person data into real outcomes. So those deeper insights matter, aggregating clinical behavioral health, social care data. It creates a sharper picture of community need. It unlocks the analytics that finally feel actionable. It helps with proactive, not reactive care. So when high-risk individuals can be identified across settings, teams move from chasing crises to preventing them. And this is where whole person data management earns its keep. Collaboration that actually sticks, unified data builds shared understanding and trust, changes the conversation from your data versus my data to our shared reality, which is the foundation of any effective network. And really, of course, at the end of the day, we all care about outcomes. So, those measurable, repeatable results, better data makes it possible to track outcomes, evaluate impact, justify investments, so that we can build, more solutions and better interoperability. And the last mile of interoperability becomes a measurable part of the care improvement equation and not just an afterthought.
Excellent. So one more polling question. So this one is multi-select. So go ahead and grab your phones again. It should be easy for you to access it. So which area do you see as the biggest barrier to achieving community-wide data quality and identity accuracy? So I think you should be able to do multi-select here. I know it says select one, but I think, well, maybe it is only one. I apologize. You have to select one. My apologies. Got a split here, 33, 50. So provider level data quality, right? It seems to be kind of topping so far. Let me scroll down here so we can make sure we can see all the responses. It's got a kind of a split between the first two. Provider level data quality, low engagement from hospitals, LTCs, seems to be now kind of jumping up as number one. So it kind of gives you a feel. The first two seem to be the areas of biggest barrier, right? Integration, health data utility alignment, less behavioral health consent, workflow complexity, 7%, and lack of clear policy governance. Okay. So real quick, couple slides, and then we'll see what other questions have popped in. So the bottom line kind of ROI, if whole person data management is really what we're trying to achieve, it's not just a cost, it's really the operational necessity. If you think about today, everything's very expensive when it's manual, when you're throwing more human processes and less technology. If you invest in more technology, you get MPI, you get referential, you get work list automation, you become now more optimized, right? So your risk exposure today, which is extreme high, starts to become less of the issue, it's minimized, right? And then your outcome is really immediate ROI through reduced liability and labor savings, which is where AI and some of the new technologies that we keep hearing about and how to leverage more of automation become not the enemy, but it actually becomes part of the process. So it's a couple of key takeaways, and this is kind of where we can jump into some of the questions if Jennifer, you're seeing more, but let's just talk real quick. We got a couple minutes left.
Yep, not yet, Greg. No.
Why is this important, right? Accuracy is core, whole person view we've talked about, compliance, just some thoughts, right, to leave people with, and then jump into some of the questions. Any comments, Laura and Jennifer, you want to kind of jump in on?
Yeah, sure. So, I mean, I think this was a great opportunity to kind of showcase and highlight these areas where we need to come together and continue to have these types of discussions for awareness, for brainstorming on how to tackle some of these issues. We're leaning towards whole person view, whole person care, longitudinal records, And it takes a variety of different inputs to be able to get us there. And so by connecting those and those integrations, it's really critical to have, quality top of mind, duplications, reviewing that, merging the right records, and having the correct critical data available at the time of care. That's why we do this, right? It's sometimes you think about we're connecting the dots with tech and making things work, but at the end of the day, this has to work for the consumer, for the provider, so that we're starting to see these really increased outcomes and significant changes to the healthcare system and ultimately reducing healthcare costs.
Excellent.
Yeah, and I think just back to meeting people where they're at, but then layering on solutions that make the data accurate and actionable, and then taking into account compliance and privacy and security. So I know we're at time.
Absolutely. Yep.
Yeah, did we have, I can't see the questions. Did we have a
No.
lot of
No
questions?
more. Nope.
No more.
Okay. So last thing I'll just mention, we talked about IdentiMatch. If you didn't see the announcement this morning, we're super excited. We announced our official offering. We would love to extend to you kind of a special holiday offering for the attendees. If you need help with work list automation, scan the QR code that's on this screen. Love to talk to you more about it. Jennifer will make herself available as well, and Laura, on different things that they're seeing in their own use cases. You guys are doing a great job. I think there's a lot of great movement that we're seeing in the industry. We appreciate you being here, and I appreciate Jennifer and Laura taking the time. Any questions that you have that you'd like to address afterwards, don't hesitate to reach out to us. And we're just super excited to see some of the movement. And there's a lot of opportunity yet to improve what we're doing, but also to improve whole person care. So thanks for joining us today.
Thanks, everyone.
And
Yeah,
thank you, Greg, Jennifer, and Laura, for a great presentation. Take care.
Thank you, guys.
Happy
Bye-bye.
holidays, everyone.
Happy holidays,
Happy
everyone. Thank
holidays.
you.